While we are waiting for folks to join us, a quick um, notification we want to share with y'all. As we've always sent out, we will continue to send out our surveys so that we can get feedback for both the series at large, but also for our individual speakers. And in order to get CME codes going forward, we're going to ask that you complete the survey. So it's just a quick feedback survey about that speaker presentation. So Kim will be sending those out today as part of our follow-up. So we won't be sharing the code for Grand Rounds right now. We hope that we can get you to complete these surveys so that we can continue to improve the Grand Round series and so that our faculty can get feedback on their presentations. So that is just one change that we'll be making today going forward. All right. Uh, let's go ahead and get started. I've had the incredible opportunity to watch this talk before, and so I know it is packed with important and very helpful information. And so today we are blessed to be joined by Dr. Mikhail Akwashev, who completed his residency here at Emory with us and then joined our faculty in the General Internal Medicine Department at Grady, or a General Internal Medicine Division at Grady, and he's been there since 2015. He teaches the residents and faculty point of care ultrasound and evidence-based medicine and serves as the medical director for our Grady Anticoagulation Clinic since 2016. In that role, he's expanded the clinic and implemented multiple QI projects regarding the cascade of anticoagulation care. And we are excited to be learning with him today. Thank you, Dr. Akwashev.
Thank you for the invitation and for that introduction, Dr. Massert, who is 1 year ahead of me at Emory and always a role model to me and a bulwark of education. So I'm excited that you're in this new role. Um, I'm glad to give this talk. I'm intimidated to give a talk to this audience, but Happy New Year, everybody. Hopefully we can get through this together. I'll start with no conflicts of interest financial for this topic, but I do have some important acknowledgments, and I want to say that this opportunity to work at the Grady Anticoagulation Clinic came up in 2015, 2016, early in my life as an attending. And I want to thank Dr. Bussy Jones and Dr. Schmidt, who, even with me being very green, put a lot of trust and effort into me. And that inspiration helped sort of plant the seed for this career. So I appreciate that deeply. The outline for the talk is going to be about 10 minutes of background, which I think have the core concepts around anticoagulation that I think are most useful for most people. But then I want the audience to tell me what you want to hear. And so there'll be an audience participation. And then at the end, I have about 10 minutes of closing remarks. So to start with the history of anticoagulation, it's got a long, long and interesting history if you're curious about these things. But it started with heparin in 1937, followed by warfarin, which came from bleeding cows. If you want to read the story, it's a worthwhile read. And then there was nothing for decades until enoxaparin came on the market and revolutionized the management of anticoagulation, allowing for so many things to be done on the outpatient side. And that was essentially the status quo of anticoagulation for 20 years until dabigatran was the first direct-acting oral anticoagulant on the market, closely followed by rivaroxaban, apixaban, and edoxaban, which have now grown to sort of dominate the market. Our own local history is Dr. Wenger started our Grady Anticoagulation Clinic many years ago. It was one of the first, if not the first, anticoagulation clinic in the country to manage warfarin and help our warfarin patients be successful. And in 2015, early 2016, we transitioned that clinic from cardiology to general medicine, which is how I got involved. And one of the first things we did was we asked the providers that are sending us patients, well, what do you think we do? And it was apparent that they expected we did more than we thought. So 46% of referring providers thought we had a pharmacist available. We did not. 28% thought we would manage indications, meaning if it's time to stop the blood thinner or if it's time to do something else, that we would manage that, which we did not. And 35% thought that if people were better off on an oral anticoagulant other than warfarin, that we would go ahead and transition them independently, which we also did not. When we asked the same referring providers of what they think we would do as far as determining discontinuation, transitioning to DOAC, or reinitiation of bleeding, the majority of providers, at least 50%, thought that the anticoagulation clinic should be involved in that decision, if not make the decision unilaterally. And so it was eye-opening to know and to have this sort of permission from referring providers to take a larger role in managing our patients' anticoagulation. And so that helped sort of early in my career encourage me to make sure that we're doing the best job we can. And that sort of is going to transition into later parts of the talk. But to talk about the blood thinner specifically, um, this slide's going to be busy and it's going to take some time, but I think it's worth it. So we'll start with the old school ones, heparin and warfarin. They're dirt cheap to purchase, although very, very expensive to administer, in that you have to do regular appointments for monitoring or close monitoring on the heparin side. Low molecular weight heparin, the oral targeted small molecule inhibitors are much more expensive, somewhere around $6 to $10 a dose, but less administration costs. The target as a review for heparin is a thrombin antithrombin. For warfarin, it's vitamin K, which inhibits multiple protein synthesis for both pro and anticoagulants. The target for low molecular weight heparin is not the thrombin antithrombin, because the molecule is already chopped up. And so the target is primarily factor 10A, which is the same target for the oral 10A inhibitors. And the dabigatran is the direct thrombin inhibitor, which is a prodrug converted to target thrombin directly, as it's named. A couple more columns. Our clearance for heparin is primarily renal and very, very quick. Our clearance for warfarin is liver clearance, hepatic clearance, but the half-life is very dramatically different from patient to patient, which accounts for the wide variation in dosing from patient to patient. While molecular weight heparin is primarily renal, as are the oral inhibitors. They're also primarily renally cleared with some minor liver clearance. And I'll also point out that the half-lives across the drugs are fairly similar, with the dabigatran having the longest half-life. The antidote for heparin is protamine. We're getting close. The antidote for warfarin is either vitamin K if you have some time to wait, or a prothrombin complex concentrate if there's an urgent bleed. Now, for a low molecular weight heparin, there is some effect of protamine, but not very much. And direct thrombin inhibitors, there's adarucizumab, which is an antibody binding to dabigatran. But for both low molecular weight heparins and oral anti-10As, andexanet alpha is a decoy factor 10A, which binds the drug. And so the reason for this slide is the predominantly used oral anti-10A inhibitors, rivaroxaban and apixaban, have the same cost, target, clearance, half-life, and antidote as low molecular weight heparin. And so if we had to make an analogy, I'd like you to remember, if nothing else from the talk, that these oral 10A inhibitors are more like an oral enoxaparin than an easy warfarin. And I think if you need this back of the little back of the paper mnemonic kind of thing to remember, I think we have a lot of experience with enoxaparin now, and this analogy can be very helpful. Now to go into a little bit of statistics of how often this is spent. I went down the rabbit hole of Medicare spending for the 5 years between 2018 and 2025, and you could see relatively stable but gradually increasing spending on the DOACs, whereas decreasing spending on enoxaparin and warfarin. And the thing I'd like to point out is this column is a logarithmic scale. If we took it into a regular scale, the spending for warfarin and enoxaparin is negligible compared to spending in millions of dollars for apixaban and rivaroxaban specifically. With a total spending of over $22 billion, these two drugs are two of the top of the drugs that Medicare is going to start negotiating directly with insurance companies for prices. But more interestingly to me, or equally interesting, is the number of Medicare beneficiaries who take these medications. And this number, especially for apixaban, has gone up dramatically over time. And although the warfarin number of patients receiving warfarin that are Medicare Part D beneficiaries is decreasing. The overall number of anticoagulated patients is increasing and was at $6 million just for Medicare in 2022, increasing probably over $8 million, 8 million patients, sorry, today. And this data is directly from CMS. Now, Grady had a very similar trends over time. This is starting a little bit farther back in time when apixaban was new to the formulary, and similarly, warfarin decreasing most dramatically after this COVID pandemic, with apixaban overcoming rivaroxaban. And around 2014 is when around 2016, 2017 is when our DOAC use became higher than our warfarin use at Grady. And this is to bring home the point again that DOACs are not just consuming the space that was previously taken up by patients taking warfarin. It's not just taking patients off of warfarin and onto DOACs, but it's really expanding the number of patients who receive anticoagulation altogether. And that brings us to the indication. So of these, let's say 6 million to 8 million Medicare beneficiaries, what indication for anticoagulation do they have? And this is surprisingly difficult data to get. This is a function of our field, but people are either on the VTE side or on the AFib side, and there are fewer data that cover both. But somewhere around 60 to 80% of patients who are anticoagulated have atrial fibrillation and atrial flutter. Another 30-ish% have a DVT and PE, some of whom have cancer or thrombophilia. And then there's a smaller group that have LV thrombus or mechanical valves or bioprosthetic valves or other indications for anticoagulation. So 80% to 90% of patients have either atrial fibrillation and atrial flutter. And for those two indications, it is class 1 recommendations from multiple societies that DOAC is favorable for the majority of those patients. And so while we tend to focus in these talks on the exceptions to the rules are very definitive from multiple randomized controlled trials and meta-analyses of randomized controlled trials that DOAC is the preferred therapy over warfarin, not for any ease of administration, but for improved safety profile, and in some of these more recent trials, potentially improved efficacy over warfarin. For LV thrombus, the data are out, and there are cohort studies on both sides of the issue. For mechanical valves, there have been several trials of DOAC favoring warfarin for decreased stroke risk for mechanical valve. The most recent was a fairly large trial with patients with on-X aortic valves, which are sort of the lowest risk aortic valves. And even in those patients, warfarin was better. Bioprosthetic valves, there are good randomized controlled trials saying DOACs are safe. For patients with thrombophilia, a lot depends on the thrombophilia, and we could talk about that more. And for patients with cancer, DOACs are safe and effective, more so than warfarin. And so for 90%, if you get nothing else from the talk, for 90% of patients who require anticoagulation, DOACs are the way to go. And the main exceptions are mechanical heart valves, rheumatic mitral stenosis, or patients with severe thrombophilias. There are some smaller exceptions. The final point that I want to make in general, and we'll get into specifics soon, is there's a recent randomized control trial, the EPIC-CAD trial that came out of Korea, where they randomized 1,000 patients with stable coronary disease and AFib to either the DOAC plus aspirin or a DOAC alone. And they looked at both ischemic events and bleeding events. And ischemic events were rare in both arms, less than 2%. But bleeding events were up to 15% at the end of a year for patients who are on aspirin and a DOAC. With patients on a DOAC alone having a significantly lower bleeding risk. And this is a number needed to harm of just 10 or 11 patients. And this data sort of echo what previous guidelines said over previous studies, that this is the ACC-AHA guideline in 2023, and they break down for patients with chronic coronary disease who needs combination therapy and who's okay on single therapy. And I'll point out in these oral anticoagulant columns on the right, beyond 6 months, this guideline recommends DOAC alone for every patient. And so we have a large number of patients who are on DOAC plus aspirin or DOAC plus clopidogrel, and although I don't think people should be unilaterally discontinuing one therapy, it's important to talk to the specialists that prescribe them and understand very clearly if and why patients have indications for aspirin as well as an anticoagulant. And if they need an anticoagulant, strongly recommending the anticoagulant alone, especially if they're more than 6 months from their index event, whether it's a stroke or a heart attack. And so this is the next general take-home point that I want to make is to avoid antiplatelets, and those are the leading cause of bleeding with dramatic increases in bleeding. Um, and so to aggressively deprescribe antiplatelets when possible. So that's sort of the pre-prescribed talk. Those are the teaching points that I wanted to make sure everybody got. And now I'd like the audience to choose your adventure. And so I have a variety of topics, one, DOACs in kidney disease, periprocedural management, duration of anticoagulation, prophylaxis after hospital discharge, bleeding and reversal, other special populations, patients who fail DOACs, and then DOACs in cancer. And uh, please go ahead and get the poll everywhere. I'd like to have at least 10 responses so that we can um, so the trick works, but please go ahead and you don't have to register or anything like that, but you can rank which topics you'd like me to cover. And hopefully they match the topics that I actually prepared. Some of them may or may not be blank.
While folks are voting, Dr. Arpachel, we did have one question in the chat from Dr. Prop. Is growth in number of patients on anticoagulation similar or greater than growth in population?
That's a great question. So the one of the charts that I showed is a proportion of patients with AFib. And even among patients with AFib, we've expanded the DOACs have expanded the number of patients who are eligible for therapy because of some favorable administration and some favorable bleeding profile. And so now nationwide, it's over 75% of patients with AFib are on anticoagulation, and in some centers, it's over 80%. And so it's not just more people can take it. It's a higher proportion of patients who are eligible continue on DOAC. Similarly, guidelines have changed because of the DOAC's favorable bleeding profile to prolong courses of anticoagulation on the VTE side of things.
And just to let you know, Dr. Arpachel, we can't see the results populating in real time, so you'll just have to let us know how it turns out.
No, I don't see any clicks yet. Do we have any?
I know I
Um,
submitted.
you have submitted?
Mhm.
Oh no.
Sounds like there have been some votes.
I can't see the results either. Let's see if we can. Oh, we tried this right before. I'm not seeing any responses either.
Uh,
If folks want to vote in the chat, we can do that too. If you have your favorites, we can.
yeah, we all submitted ranked lists in case that sort of impacts how the votes come up. But we can also just turn to the chat and query the group.
Apologize.
No worries. It's not really a Zoom if there isn't a technical issue.
Okay, I got a tip from Varun to try and go to the Poll Everywhere website, so let me try that too. Oh, our hero, Dr. Fadki. So we've got 74 responses, quite a few. Thank you all for your participation. Um, and periprocedural management wins. And and I'm glad to go through those. So let's start with periprocedural management and bridging. Let's see. All right. And as an example case to put in your head, although you may have cases that you've seen recently, this is a 75-year-old with a history of hypertension, heart failure, diabetes, and they've been taking apixaban for a history of DVT 1 year ago. And they're doing a colonoscopy next week, and we need to decide how to manage their anticoagulation for this upcoming procedure. And our options are we could just stay on the anticoagulant. We could stop the anticoagulant and switch to a different one. We could stop the apixaban for 5 days and not switch to a different one, or just stop the apixaban for 1 day. So think about what you would do in your head. But while we talk about it, the things that we need to sort out are, do we need to stop anticoagulation at all? Is that important for this procedure? If we do need to stop the anticoagulant, is it safe to stop the anticoagulant, or do we need to try something else? And if we are stopping and we have this person who needs a blood thinner for some reason and we stop, should we do a bridge, or should we give them some sort of protection while we stop? And this is a thing that is definitely practice changing from the warfarin days, and I think some practices have caught on quicker than others. And to answer the first question of should we stop AC risk at all, um, multiple societies sort of come together to give up these recommendations of minimal or low risk procedures. These are simple dental extractions, cataracts, incisions, and these are procedures that can be safely performed without stopping anticoagulation. And then there are those more complex versions, and some are very similar procedures that the anticoagulant should be stopped. Now, the important caveat is when I talk to our cardiologists here, they convert some proportion of their caths or PCIs from radial to femoral. And so if the patient has been taking a DOAC, then they can't safely convert. Or if somebody has a diagnostic colonoscopy and they see a polyp, some of our gastroenterologists may be uncomfortable pulling that polyp. And so for patients undergoing procedures, this procedural risk really lies with whoever is performing the procedure, the surgeon or proceduralist. And so it's important to discuss each patient with them procedurally. But now, if you've decided that this patient has a procedure for which they need to stop, and this colonoscopy, if we're suspecting a malignancy where we strongly need a biopsy or an excision, um, and we need to stop, the next question will be, is it safe to stop the anticoagulation? And this is where the internist or the expert managing the anticoagulation comes into play. And the question is, what's going to happen if we stop? What's the bad thing that could happen? And these are the highest risk patients who are anticoagulated, and the bad things that can happen to them are going to be strokes and systemic emboli. So among thrombosis patients, if a patient has had a clot within the previous 3 months, or they have a history of thrombophilia or malignancy, those patients have the highest risk of recurrence, and that's at least 10% annual risk. On the AFib side, it's similar. If they've just recently had a stroke within the previous 3 months or have rheumatic mitral stenosis. And on the mechanical valve side, it's any patients with a mechanical mitral valve prosthesis or very old valves, or similarly, patients who've had clots within the previous 3 months. Now, these are the patient populations that have 10 to 15, sometimes even as high as 20% annual risk of stroke or systemic embolism. And for some of these patients, if they're having an elective procedure, an elective colonoscopy, and they just had a large pulmonary embolism, for example, it may be good to push the procedure off or see if we could do something else, like doing an occult blood test or a FIT test of some sort. But sometimes it's impossible to push off the procedure, right? We have a malignancy. We need to address this malignancy regardless of the um, recency of the clot. And so then we need to decide if we need to bridge. And the idea for bridging is there's this time period where the patient is going to be stopping their anticoagulant. And so can we do some other anticoagulant? that idea, the philosophy comes from warfarin because of its long half-life. Patients need about 5 days for the warfarin to wash out. So you have to hold it for a while, and then it takes another 3 or 4 days for the warfarin to kick back in. And so the idea became, well, can we use low molecular weight heparin to cover these patients? And that sort of became common practice without any studies to approve it. The first major trial to test this idea was the Bridge study, with nearly 2,000 patients. They were recruiting all patients with AFib, but mainly ended up recruiting lower risk, lower to moderate risk AFib patients. And they compared a 5-day bridge versus no bridge perioperatively. And what you could see is without bridging, the risk of stroke or systemic embolism in this population was less than 0.5%. And you really can't improve that with a blood thinner. And so even after, it remained less than 0.5%. Unfortunately, adding this second blood thinner increased the bleeding risk periprocedurally from about 1.5% to over 3%. So more than doubled. And so this is really a therapy that dramatically increases bleeding risk with a minimal, if any, benefit. Um, the critique of this trial was it only ended up recruiting lower risk patients, and there was a subsequent Periop 2 trial which recruited higher risk atrial fibrillation patients as well as patients with mechanical heart valves who were taking warfarin in a multinational trial with a similar design, either a low molecular weight heparin or placebo periprocedurally. With very similar results. Whether or not you bridged, you had about 0.5% to 1% risk of clot, and whether or not you bridged, you had a dramatically increased risk of bleeding if the patient had enoxaparin periprocedurally. And so these are pretty definitive evidence that even for warfarin patients, bridging may not be the best idea. But what do you do with a DOAC? As we talked about earlier, the half-life for low molecular weight heparin is very similar to apixaban or rivaroxaban, which are the most commonly used DOACs. And so this pause study was a prospective cohort of 3,000 patients where they just followed the instructions on the package insert. And the instructions on the package insert were as follows. If a patient has a high bleeding risk procedure, they would hold for 48 hours before and 1 day and resume on post-op day 2. And this is open thoracotomies, open abdominal procedures, things like that. And if a patient had a low bleeding risk procedure, they would hold for 24 hours before and resume on post-op day 1. Yeah. And they just did what was on the package insert and followed these patients to see what the outcomes were. The majority of these procedures were colonoscopies. However, there were lots of other open abdominal surgeries and other procedures. And the results were about the same. This is whether you were on apixaban, dabigatran, or rivaroxaban, the major bleeding rate was similar to previous studies, and the arterial embolism rate was similar to previous studies. This is the control group from the other study, from the Bridge study. And you could see for patients who just received placebo in the Bridge study, a separate study, they had very similar uh, rates of bleeding, clotting, and embolism. And so uh, the results from the periprocedural management are pretty definitive. Don't bridge. Don't bridge DOACs because essentially they're the same as oral enoxaparin, and if you can hold, you can hold as long as you need to. And you should bridge warfarin only in the very highest risk patients. So the patients who have active cancer, who have a recent thrombosis, and only if they're on warfarin and mechanical mitral valves. So that's our periprocedural risk. And that's a pretty good segue and has some similar overtones as to how long to anticoagulate patients. And there's multiple uh, ter aspects to this question of how long should the patient be anticoagulated? Are there patients who should go longer? And are there D-dimers or other tests that can be helpful? And who needs thrombophilia testing? And so I'll give an example of a 40-year-old man with a history of unprovoked right upper lobe pulmonary embolism 6 months ago. They had a repeat CT at 1 month that showed that the clot was gone, and the patient asks if he can stop his rivaroxaban. And so your options are it's safe to stop, and then you could switch to aspirin. You could check a hypercoagulability panel. You could check a D-dimer. could say this patient should stay on rivaroxaban indefinitely, or we could switch to apixaban as an alternate therapy. And I will say that this isn't 100% a right answer for every single patient, and this will vary from patient to patient. But the general theme for how long to anticoagulate is you want to anticoagulate long enough so that they don't have another clot, but you want to stop before they have a major bleed or another complication. And that can be very tricky and clearly varies from patient to patient. The 2021 CHEST guidelines um, simplified it by putting these treatment into three specific phases based on the physiology and the risk of clot. So there's a very initial hyperacute phase of 1 to 3 weeks, a treatment phase of the first 3 months, and then an extended phase after 3 months. And I think this has been the most straightforward approach to this. Now, the duration of treatment, the background comes from this cohort study where they looked at patients who had a VTE and were given anticoagulation and stopped after different periods of time. And there was a group of people who stopped between 1 and 1.5 months, a group of people who stopped between around 3 months, around 6 months, or 12 months or longer. And this looks at the rate of recurrence of VTE. And what you can see is the most likely recurrence is within the first year. And within the first year, it's within the first 6 months. Within the first 6 months, it's really within the first 3 months. And within the first 3 months, it's really within the first few weeks after discontinuing anticoagulation. And moreover, the group that got 4 to 6 weeks of anticoagulation had a much higher rate of recurrence than the groups that got 3 months, 6 months, or 12 months of anticoagulation. Looking at these as Kaplan-Meier curves, you could see that after around 6 months, the curves, even around 3 months, the curves become parallel. And after the patient stops, they basically revert to their baseline risk of thrombosis. Whereas in the first 1 to 3 months, the patient is at an elevated risk. Whatever happened, circumstances were ongoing that caused the first clot, plus the milieu of whatever's going on around the clot, uh, is likely to set off another clot. And so based on this, really clot recurrence is highest in the first 3 months after a VTE, and everybody, assuming low bleeding risk, should receive at least 3 months anticoagulation. After 3 months anticoagulation, generally for patients, whatever circumstances occurred around the first clot have resolved, and the patient returns to their baseline risk. And so if at baseline there was really no circumstance that caused the clot, then they return to that same elevated baseline risk. And so that's the question of who needs more than 3 months. This cohort study was sort of the definitive study where they looked at the recurrence of VTE based on the provoking factor. And if the patient had a surgery, like a hip surgery or knee surgery that caused the clot, in the 6 weeks prior to the clot, their risk of recurrence was around 2%, which is essentially population level. For patients with a non-surgical risk factor, this is like birth control, cancer, malignancy. Um, these patients had about a 10% 2-year risk of recurrence, and patients with no identifiable risk factor seem to have the highest recurrence risk, approaching 20% at 2 years. And this, so this concept is the less it took to get the patient that clot, the more likely that clot is to come back. And I have patients once in a while who say, oh, I was studying for finals, and so I was in my room for a long time. Or I took this car ride all the way to Birmingham, Alabama, which is just 2, 3 hour car ride. Well, if that's all it took to get this patient a clot, then they're really at increased clotting risk as compared to somebody at Grady who had a motorcycle accident, broke their leg kind of thing. And if that's what it took to get a clot, then the risk of recurrence once that heals is very, very low. To supplant some of those discussions of provoked versus unprovoked, which is the single most important determining factor for recurrence, for unprovoked clots, there are some other things, other scoring systems that can be helpful. For our patient, for example, he was male and he was less than 40 years old. He wasn't using any hormones. And his D dimer, assuming it was normal, uh, you could get an annualized recurrence risk of 2 points, would give him about a 6 or 7%. annualized recurrence risk and a 5-year recurrence risk of 25%. And so it's very nice to be able to have these conversations with patients because at around 3 months to 6 months after their clot, they've experienced both the blood thinner and the clot. So you can really have a patient-centered conversation saying that, there's a 1 in 4 chance that you have another clot by the time you're 45. Is this something that's worth taking a blood thinner for you? Now, if his D dimer were abnormal, that may change things dramatically, and his recurrent rate might be up at 60% or higher. And so some of these scoring systems can be helpful. For women specifically, there's a HER2 score or Vienna score for general patients, all that use D dimer to sort of help stratify patients. Similarly, the recent ASH guidelines have this chart that sort of uses multiple data sources to compare the risk of recurrent clot versus the risk of bleeding that can be used to talk when you're talking with patients. Um, but what we end up in a lot is patients who potentially could stop or potentially could keep going. And we're in this gray area. And I'll give you an example. We had a recent patient who had a very high risk thrombosis, a large pulmonary embolism that was strongly provoked by a trauma. And so this is a patient on paper, you could say, well, it was very strongly provoked, very low risk of recurrence, but he had a very large clot. And potentially, if that did recur, that could recur again as a very large clot. And so it can change the conversation. And so there are a few trials in that setting of clinical equipoise that can be really helpful to have in your back pocket. This was the Amplify Extend or the Einstein Choice trial, which had similar ideas. For Amplify Extend, for these patients who completed 6 months of initial anticoagulation after their first unprovoked clot, they were randomized to placebo, apixaban 2.5, or apixaban 5. And the thing that's important to remember when you're applying this data is whatever physician enrolled them in this study was okay with them being randomized to potentially get a placebo or randomized to potentially getting full dose anticoagulation. And so this is not to supplant that patient who has recurrent clots or things like that. This is the patient who you think might have been okay with a placebo. But the outcomes were dramatic in that 2.5 of apixaban was almost as effective, essentially as effective as apixaban 5, with a number needed to treat of just 13 patients compared with placebo to prevent a clot at the end of a year. Moreover, the bleeding risk with apixaban 2.5 was more on par with placebo than apixaban 5, and this is major or clinically relevant non-major bleed. And this number needed to treat was much higher. But it seems that at least for the first year after their clot, apixaban 2.5 in these patients with clinical equipoise gives you some of the best of both worlds. Some lower clot risk, just like a full dose anticoagulant, but lower bleeding risk similar to placebo. Soon after, a similar trial came out with rivaroxaban. In this one, they had provoked and unprovoked clots, and they used an active control in the form of aspirin. However, the outcome data were similar, that rivaroxaban 20 milligrams was about as effective as rivaroxaban 10 milligrams. However, the bleeding data were less convincing, especially considering they had an active control. Um, so in general, if you have patients on anticoagulation, the duration should be at least 3 months. If they have a strong provoking factor, and low risk for recurrence of clot, those patients can stop at 3 months. If the provoking factor isn't resolved, for example, their mobility isn't improved after their trauma, or they have additional surgeries, or they have a cancer that continues to be active, then you should extend the anticoagulation. Or for unprovoked clots, you should offer extended therapy according to the most recent chest guidelines. Now, the thing that we haven't talked about is, should we order repeat imaging to make sure the clot is there, the clot is gone, or should we order a hypercoagulability panel? As far as repeat imaging, the answer is a pretty definitive no. Any clots that are persistent on imaging at 3 months do not represent an increased risk of thrombosis later. And I explain to patients that they're like scars inside the veins. However, this hypercoagulability panel, that sort of has been persistent. And I'll give you an example. If we took a room full of people, similar to we have here, 100 some people, and we checked for hypercoagulability panels, we would have five patients who would have some kind of genetic predisposition potentially to thrombosis. And one of them would have a positive, would have a clot at some point. However, we would have another nine patients who would have clots despite the negative hypercoagulability panel. And similar, you could apply similar statistics to a stadium. If you took 50,000 patients to screen for gene mutations, you would have about 2,500 with some kind of gene mutation, of whom only 250 to 500 would have clots. Even among the most common gene mutation is factor V Leiden, and even among homozygous individuals, many of them, the majority of them, will not have clots. But that's backwards, right? That's screening a healthy population. So what happens when you screen patients with a previous clot history? So this is a case control trial of 474 patients with their first unprovoked, with their first DVT. 55% of them were unprovoked. They screened this population for thrombophilia, and they found that 20% of them had some kind of factor V Leiden abnormality, but they also had other things. And when they looked for the cumulative incidence of recurrent clots, the thrombophilia patients had at 12 years a slightly higher clot risk, but I would say clinically it would be hard to tell 20% versus 30% clot risk in this population. And so once you have a patient who's sort of declared themselves as having created a clot, it doesn't matter what gene abnormality caused that clot. If there is a gene abnormality, that patient has this phenotype of clotting, which is sufficient. The interesting follow-up of that same study is when they looked at which gene mutations were associated or physiologic deficiencies were associated with thrombosis. Actually, the associations were relatively weak with thrombosis, with protein CRS being the highest associated, but even factor V Leiden wasn't strongly associated with thrombosis in this study. So the take home is continuing anticoagulation in patients who are very high risk of clot, especially if they're at very low risk of bleeding. And anticoagulation panels or repeat imaging really don't go into this discussion dramatically. All right. Our next topic of interest, and will probably be the last topic we'll have time for, so you'll have to invite me back if you want the DOAC failure, is special populations. So these are patients with obesity, cerebral venous sinus thrombosis, pregnancy, LV thrombus, rheumatic atrial fibrillation, thrombophilia, and frailty. And we'll start with venous sinus thrombosis. This is one that's a little bit niche. I don't think we see very much of it, although it can be dramatic when you see it. This is one initially where DOACs were thought to have low penetration into the CSF, and that was one of the reasons they thought they had less intracranial bleeding than warfarin. But on the flip side is, well, are they adequate for cerebral venous sinus thrombosis? This was a meta-analysis of 19 studies, 13 randomized control trials, and multiple cohort studies, which consistently showed, if anything, less recurrent VTE, less major bleeding, less intracranial bleeding, and less death with DOAC. And so these differences were not statistically significant, but if anything, trended towards improvement with DOAC. And so for venous sinus thrombosis, DOAC seems adequate. For patients with cirrhosis, this is another, the DOACs are potentially liver hepatically cleared, although so is warfarin, and cirrhosis is a risk factor both for abdominal thrombosis, hepatic vein thrombosis, and peripheral thrombosis. And so this is an important clinical question. The official package insert recommendation is to not give DOACs for Child-Pugh B and C patients. Um, but this study looked at patients with chronic liver disease and new anticoagulation, and they followed them in a prospective fashion, looking for risk of ischemic stroke or major bleeding. And they found that the DOACs were at least as safe as warfarin, if not safer among these patients. This was another study for AFib and cirrhosis, again from a large retrospective cohort. that was propensity matched, again, showing no differences in efficacy with a potential advantage and number needed to treat of just 29 for an advantage in patients with cirrhosis. And so if you do choose, if the patient is, if you think the risks of anticoagulation outweigh the benefits outweigh the risks rather, then DOAC is a reasonable choice. Obesity is another contentious topic, and it came because the original thrombosis and hemostasis guidelines, based on the original RCTs, there were really a relatively small number of patients who weighed over 100 kilos, and so they recommended avoiding DOACs in patients over 120 kilos or a BMI of 40 at the time, because of lack of data, not because of data supporting lack of efficacy. Since then, there have been multiple cohort studies, and the cohort studies had an interesting paradox. It looked like patients with normal weight tended to have a higher risk of stroke than those who are overweight or obese. And increasing weight in patients with atrial fibrillation seemed to confer a protective effect unexpectedly. There's data in VTE patients are harder to come by generally, but had similar data as well that there may be a protective effect in these sort of moderate overweight patients from stroke or systemic embolism. This is another retrospective post hoc analysis of one of the big DOAC randomized control trials, again showing it's the lower extremes of weight that are more likely to have strokes or bleeds. And as weights went up, bleeding risk and stroke risk actually tended to go down. And so based on this, the ISTH updated their recommendation, saying that there were similar outcomes for patients with BMI over 40 as there are with patients with BMI under 40 for apixaban and rivaroxaban in the pooled DOAC cohorts. And so as of 2021, we've liberalized at Grady which patients we put on DOAC because of new data that seems that it's safer, if anything, maybe more effective in obese patients. For pregnant patients, apixaban did a study in bunnies that said it was a class B for birth defects, although it's consistently among multiple societies that recommended not to use any DOACs in pregnant women or breastfeeding women. There are registries that are looking for complications from DOAC therapy, from accidental DOAC therapy, all these other things. But generally, the mainstay has been to use low molecular weight heparin. The exception is for patients with mechanical heart valves, and there are good data that low molecular weight heparin isn't as effective as warfarin in patients with mechanical heart valves. And so the cardiology guidelines, if you can use very low doses of warfarin, recommend, particularly in the second and third trimester, switching back to warfarin. And this is something that you should do working closely with maternal fetal medicine and or the anticoagulation clinic. We have one or two patients, women a year, that are pregnant on warfarin that we manage in our Grady anticoagulation clinic. For LV thrombus, there were trials that are back and forth. This Red Velvet study suggested that warfarin was better. Other trials suggested that DOAC were better. And as the meta-analysis of the retrospective cohorts for bleeding complications seem relatively similar. And for stroke or systemic embolism, the sum total is also relatively similar. So the guidelines recommend that it's reasonable to try DOAC, but that's not definitive. Thrombophilia and antiphospholipid is one that's gotten a lot of press recently for good reason. The first trial that came out that showed a strong signal for increased thrombosis in patients with antiphospholipid was the TRAPS study out of Italy, which showed an increased risk of stroke or systemic embolism. And since then, there was a similar trial in apixaban and a really well done meta-analysis. Now, the important thing to know is antiphospholipid syndrome comes in two flavors. It comes with women who have miscarriages and very few other thrombotic complications. And then it comes in the flavor of multiple arterial and venous emboli, um, and potentially very, very high risk clots. There's a test for antiphospholipid syndrome, which comes in multiple parts. They check two antibodies, um, and then they also check for intrinsic coagulant activity. If the patient is taking an anticoagulant, some of those tests might be abnormal, and the antibodies can be false positives too. And so, to really make a diagnosis of antiphospholipid syndrome, you need to repeat this test and be persistently positive 12 weeks apart. Um, and so, but when I have young patients who have arterial and venous thromboses, I do check for antiphospholipid syndrome. Um, and specifically, DOAC was adequate in preventing VTE in these patients, as good as warfarin, but was far inferior to warfarin at preventing strokes or systemic emboli. And if you look, it's almost in every subgroup, as far as arterial embolic events, whether they're men or women, particularly in women, whether or not they've had a history of arterial events, whether or not they're triple positive or single or double positive, those patients tend to do better on warfarin than on DOAC. Finally, rheumatic mitral stenosis, there was a randomized control trial saying warfarin is better, with the number needed to treat of 58 to prevent primarily stroke and death. And so for patients with rheumatic mitral stenosis, the RCT suggests it. And there was a recent trial that was very well done in elderly or frail patients. Now, before we get to the trial, I want to talk about a cohort prospective, well done prospective cohort where they looked at patients with AFib and looked at whether or not they were frail and the risk of complications with anticoagulation. And the frailty itself didn't seem to be a strong determinant, but in this study, cognitive impairment was associated with worsening outcomes. What I really like about this study is they looked at this number needed to treat and number needed to harm. And so the number needed to treat to prevent a stroke in patients with impaired cognition was 30 patients. However, the number needed to harm to cause a bleed was on the order of 5 to 10, and to death 20. So this is really in patients at high risk for these complications of bleeding or death. Um, Anticoagulation should be used with extreme caution. But this randomized control trial, I think, was paradigm changing for multiple patients. This was done in the Netherlands, where they found 1,300 patients who were 75 and older and stabilized on warfarin. They had been taking warfarin for a period of time, and they randomized these patients to continue their warfarin or to switch to a DOAC. And they had to stop this trial early because the patients who switched to a DOAC had worse outcomes. They had a statistically higher rate of first bleed. Um, and this is a very interesting thing. When you have a patient group that self-selects for doing well on a medication, even if that medication is warfarin, they've already done well on it. You've kind of weeded out the patients who had complications. So then in that case, switching to DOAC in these patients was associated with increased complications with a number needed to harm of just 21, which is counterintuitive for folks and has been paradigm changing in the field. All right. So whirlwind tour. I have a few closing thoughts. These are more related to some work that we've done specifically at Grady that I wanted to point out, and then I do want to save some time for questions. The first trial or the first study that we did was sort of an obvious study in hindsight to say, well, let's look at our obese patients and let's see if they do better on rivaroxaban or on warfarin. And if you look, we had 42 patients, but only around 70 or 80 had any signs of obesity. And we really didn't, with 80 patients, weren't able to show any advantage or disadvantage to one therapy or the other. And in hindsight, this study was doomed from the start, right? We'd never had enough patients to do this study. And it would take at least 1,000, 1,500 patients to show differences in those kind of outcomes. And this, as an early faculty member, I was at Grady, and I had a meeting with Dr. Lennox, who pointed out to when you're at a institution like Grady, you really want to lean into your strengths. And so he talked about looking into the cascade of care. And so we kind of wrote on a back of an envelope what the cascade of care is from the diagnosis to treatment, referral to clinic. Then they have to get scheduled to clinic, actually show up to clinic and pick up their medication and take it and be successful without bleeds or clots. And so we tried to figure out how do we sort through all of this. Um, One of the first things we found is patients who come to our clinic had a pretty good 3-month adherence, 73%. But when we kept looking, we realized patients who didn't come to our clinic had a terrible, abysmal 3-month adherence of only 28.9%. And so we realized that this is a bigger problem than just patients in our clinic. It really needs to be patients in our health system. And when we looked, patients with warfarin were even less likely to pick up their medications at 3 months than patients or with rivaroxaban were less likely than patients on warfarin. And so we went back to the beginning. We couldn't figure out how many people were diagnosed, but we looked at how many people were started on therapy um, by making order sets. And anybody at Grady who orders an anticoagulant has to go through this order set. And so we know that there's about 200 uses of the order set a month for VTE and about 100 for AFib. And so that's probably 300 patients a month on the inpatient side. We also figured out how many of these are referred to our clinic, which is similar to how many starter packs we get, which is we have about 200 referrals a month, which is uh, uh, around right. And some of these are chronic medications, some of these are acute. And we have about 40 new starter packs a month that we give out for patients who have new to anticoagulant. Uh, we found out that the majority of these patients are scheduled in clinic, but we do lose a large portion around showing to clinic. And our 3-month adherence was low. We did a follow-up study to see if telehealth impacted this as we switched our clinics to telehealth during COVID. And what we found is post telehealth, our appointment completion rates went up from 45% to 55%, as they did in primary care. But unfortunately, our medication persistence rates, if anything, trended down. And then, although it is easier to complete the appointment with the patient, that we weren't converting that to the patient actually picking up their refills. And so we learned that we still have a lot of work to do. So, as a summary, DOACs are like oral enoxaparin, and they're preferred for most patients, excluding mechanical valves, mitral stenosis, antiphospholipid syndrome, and a handful of other populations. Adherence or monitoring are critical, and that is sort of our next step at Grady. We know what the right therapy is, but how do we help patients be successful and manage their social determinants of health to get the therapy that they need and deserve? So, with that, I have just a few minutes left, and I want to respect folks' time, but I would like to take questions if they come up.
Thank you, Dr. Akrashev, for that excellent presentation. I always learn something new, even though I've seen this a few times, and it's so relevant to our practice on a daily basis. What questions do we have?
Thank you, Dr. Ray, for your thoughtful comment. I've had the best teachers to learn from, so thank you.
Dr. Law wonders, what's the best way to refer to the anticoagulation clinic?
Yeah, that's a great question at Grady. We have several different orders available. Any of those sort of go into the same work queue. So you can, if they're on warfarin, you can refer to the warfarin side. If they're on a DOAC, you can refer to the DOAC side. We're also glad to help manage anticoagulation as far as duration of treatment and the appropriate anticoagulant. And we work with the referring providers and the managing providers. Dr. Massey has a great question about when is rivaroxaban preferred over apixaban. I mostly think of them as Coke and Pepsi. Apixaban has better data as far as bleeding. But even enoxaparin shots, they're available as 1 milligram per kilogram twice a day, which is what we use mostly in the United States. But in Canada, they use 1.5 kilograms, 1.5 milligrams per kilogram once a day, this big slug once a day. And that dose in trials has a great efficacy, but slightly higher bleeding. So that's what I think about as rivaroxaban is that big slug of the same kind of medication once a day. And so you get a higher peak and higher bleeding complications. So if you have patients who eat consistently and prefer to take a medication once a day and are a lower bleeding risk, I think rivaroxaban is a great option. Some of the more nuanced data around frail patients and rivaroxaban being on the Beers criteria, or some of the more niche data about obesity, I think tend to be more statistical anomalies than definitive data. And so I think those are sort of less strong indications. But if you have a patient who strongly prefers to take a once-a-day medication, then rivaroxaban is the way to go. It sounds like we should not do anticoagulation work for most people with clots. When should we consider antiphospholipid screening? That's a great question. I think when you have very young patients who have arterial and venous clots, those should definitely be tested. For young women with histories of multiple miscarriages, those patients should be tested. For patients with known rheumatic disorders, like lupus or rheumatoid arthritis, mixed connective tissue disease, those and they have a clot without a clear provoking reason, those should be tested. And then my own practice is to also test patients who have clots while on anticoagulation to try and explain why they've had a clot, although that has not been a strong hit rate. I don't find a lot of antiphospholipid syndrome. Testing in the moment is problematic for antiphospholipid syndrome because the DOAC can act as an inhibitor. And so if you're considering any of those populations, it's not unreasonable to get a hematology consult.
Any other questions?
All right. Thank you
It's
again for the
an
invitation.
impressive
I really
talk.
appreciate it.
You landed right on time. Even more impressive in academia.
It's easy when the talk can grow and shrink.
All right. Well, thanks everyone for being here. And just a quick reminder to get the CME code, please complete the feedback survey that Kim has added the QR code to the chat and will be in the email as well. Upon completing the survey, you will receive the CME code so that we can get some feedback on the series as well as Mikhail getting some feedback on his talk. Thanks everyone for being here. Have a great week and stay warm out there.